how did you end up in orthopedic research? I know you've had kind of a twisty journey to here, so fill us in.
Yeah, so came through the UK's rehab science program. So had an athletic training background, very clinical biomechanics type of research was what I did my dissertation on. Was looking at the relationship between hip muscle function and knee biomechanics, and as it relates to like ACL injury is kind of how I started. Then a colleague at a local private practice here in Lexington was looking for someone to help out with their hip replacement and knee replacement research. So initially took that gig, thought it was going to be a short time thing. Ended up being there for like 4 years. That transitioned into working with a small kind of startup company in Atlanta, more on the industry side. So was the director of research and development there for a few years, and then came back to Lexington, where the kids were born. That one, it just fit us a little bit better. Yeah. And came back to the Lexington clinic, worked there again, and then eventually transitioned back over to UK. So what started out as all sports, then transitioned to all joint replacement, and then quickly realized there was this huge gap of people that are in between the two. That's really where the excitement is for me. So that's the large group of patients that don't really have a viable treatment option. So that's what gets me up every day.
Yeah. Well, and I think your studies run the gamut in OA, right? I mean, I've worked on clinical trials with you about PTOA. We've done, like you said, total hip and total knee replacements. And so, when you talk about those people in the middle, kind of explain to me, like, which patient population you're really, kind of referring to, because we're at the two ends of osteoarthritis, but there's a whole lot of people in the middle.
Mm-hmm. And I think it's kind of coming at it from two different ways. So I think oftentimes people try to put the progression of pain and the progressive like cartilage breakdown that goes with arthritis, they try to bundle that all together. And that it's, this person's progressing, and that they're both, their cartilage is breaking down and their pain is getting worse. What we've seen is that there's really, it's almost two separate processes. Mm-hmm. And definitely for those folks that are in the middle, in the gray area, before they're, they haven't had cartilage breakdown that would warrant a joint replacement. But you have a lot of folks in between where they might have pain that's much more severe than their x-rays, or vice versa, folks that have just really ugly x-rays, but no pain whatsoever. Okay. So I think we have to almost pursue both of those independently. Mm-hmm. So, what's going on in terms of OA pain might be very different than what's going on in terms of cartilage breakdown. So that's really been kind of the fun part, is wearing those two different hats and trying to kind of crack the code on arthritis pain and patient-reported outcomes. And then also looking at different inflammatory factors, biomechanical factors, and what really goes into that cartilage breaking down.
Yeah, absolutely. Well, we got the pleasure to speak with Dr. Caitlin Conley, who's a colleague of yours, about patient-reported outcomes and about how she, sort of fell into the PRO world after her dissertation. And, I think you have been such a mentor to me in terms of the biologic side of it, but that really wasn't your background. You came from sort of a biomechanical, more functional background. So how did you land in the inflammatory world and and working with all of these different drug trials and things like that to try to get at this cartilage breakdown question?
Christian Latterman. So my former colleague at the University of Kentucky, your current mentor at Brigham and Women. Yeah, Christian was the impetus there. So I wasn't in that biologic space at all, and really got to looking into patient-reported outcomes more out of curiosity for why different interventions weren't working when they should, right? So that if on the biomechanics side, if there was a new implant design, this should make everyone better because it moves more like the normal knee. But you still had 20% of people that didn't get better. So it was really diving into why. Well, what is it with these patient-reported outcomes? What's really going into this number that we're kind of grading whether or not this surgery was a success or whatever treatment was a success? So it's trying to learn more about that. And I think that same curiosity then applied on the biologic side. So if we had this biomechanical intervention, let's say an ACL reconstruction, where we've restored the native knee kinematics pretty well, right? So now it's a stable knee, but they still progress to arthritis, even though the knee feels good, right? So it feels stable. They can run and cut. They don't have pain. But why is their cartilage breaking down? Why is it that 80% of people have arthritis, 15 years down the road if they've had an ACL and a meniscus tear. So it's really trying to fill in the gaps. So where are the curiosities? And that's always the funnest place to work.
Yeah. Well, and I think, what's so important there, and then you talk about the difference between, pain and cartilage breakdown. And we talk about how, not everybody, right, goes on to get post-traumatic osteoarthritis. So, of all the people who tear their ACL, about 50% go on. So where are those differences? And I know, when I was at Kentucky, we started to kind of look into the inflammatory process and see, if it was having to do with that. We looked at, IL-1 beta levels, and you coined one of my favorite terms, inflammatype. And actually we were fortunate enough to run some analyses and see that there are differences. So maybe, can you talk to us a little bit about how you're starting to think about bucketing these people for treatment, right? So when they come into the clinic, how do we determine who needs what, since we know that there's no silver bullet, not one treatment's going to fit every patient?
Mm-hmm. Yep. I think we have to kind of embrace those interpersonal differences. So after ACL reconstruction, we saw that there was about a third of patients that have a somewhat broken inflammatory response. So it just doesn't respond. That person doesn't respond to an injury the same way as everybody else. Mm-hmm. So after an injury, inflammatory markers go up. And that makes sense, right? Or after injury or after surgery, it's like that's how it should work. But normally how it works is that our own bodies have an anti-inflammatory response that also increases, right? So it's kind of like in parallel. You get a pro-inflammatory response and an anti-inflammatory response. But for this one group of patients, they don't have that innate anti-inflammatory response. So their inflammation kind of goes unchecked. So all the bad things that can happen, it can spiral out of control a lot faster for that person necessarily than someone else. There's this third of patients that we just refer to as the inflammatype. So that's this group that has this pro-inflammatory response to injury. And what's interesting, and you don't know this yet, is we partnered with Justin Haller at the University of Utah because they collected a lot of the same data with patients that had different fracture patterns. So both tibial fractures that are at the knee joint, but also tibial fractures that are in the ankle joint. And when we controlled for the different injuries, we still saw that it was about 25 patients that showed this same response. So it doesn't seem to be like injury specific. It does seem to be that there's just a certain percentage of us that are wired to respond to injury a little bit differently.
There's no shame in asking other people for help and bouncing ideas off everybody and just sort of, trying to make the most out of the opportunities that you're given. So.
Yep. And yeah, don't be nervous to speak to some of the more established researchers. Virginia Krause, who's a rheumatologist at Duke, she's absolutely giving with her time and her ideas and has always been fantastic. So there's always willing to answer the phone or respond to an email if there's any cockamamie idea I might come up with.
Yeah, that's great advice. I think I'm always mildly petrified, but hopefully with some practice.